To all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar education opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability for any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from the use of the video content, which is provided as is and without warranties. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, then swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from the website tomorrow. Dr. Julia Fink is a board-certified orthopedic surgeon at Nemours Children's Hospital in Florida. Dr. Fink attended medical school at the Philadelphia College of Osteopathic Medicine's Georgia campus prior to her residency in orthopedic surgery at Jack Hughston Memorial Hospital in Phenix City, Alabama. She continued her training with a fellowship at Children's Healthcare of Atlanta at Scottish Rite in Georgia. Dr. Fink has been recognized by the American Orthopedic Society for Sports Medicine with a STOP Award, which recognizes outstanding research related to youth sports injury prevention, treatment, and rehabilitation. She is also a national champion collegiate softball player and team captain. She is presenting today on OCD lesions, and I'll have you take it away.
All right, you guys can all hear me?
They can, and if they have any issues, I'll be monitoring the chat.
Perfect. Okay, so we're going to go ahead and get started. I take care of a lot of pediatric athletes in my practice, and so we're going to go a little bit over osteochondritis dissecans in these young athletes. So I have no financial disclosures. Just quickly, you kind of heard my little spiel. I grew up playing softball. I was an athlete myself. I've had lots of my own injuries. I went, and in high school, I did athletic training. That's actually something I considered doing even in college. Took a different round, did orthopedic surgery instead, but I helped take care of the athletes at Lakeland High School and Bartow High School. And I also volunteer and do some faculty membership stuff at UCF. So here's just what kind of we're going to go over today is a little bit about OCDs, what they are, what you see on exam, some pertinent imaging, and some treatment considerations as well as rehab. So I have a couple different cases to go over, 1, 2, and 3. 2 of them are knees, 1 of them is an elbow. First being a 17-year-old with left knee pain for 2 months, had a soccer injury, effusions afterwards, feeling of popping and unable to extend his knee. The second case is going to be a baseball catcher with pain in his elbow for 6 to 7 months, swelling, no known injury, but loss of terminal extension. And the third is a 14-year-old female who had a patellar dislocation 2 years prior, but continuing to have locking, catching, and swelling in their knee. So OCDs are essentially can cause pain in any joint, usually associated with recurrent effusions, not always associated with any type of pain. Sometimes they have an insidious onset. It's most commonly in the knee, but you can also see this in the capitellum about the elbow as well as in the talus and the ankle. It can be difficult to pinpoint exactly where the pain's coming from, but the most common place in the knee is going to be medial, laterally on the elbow, and then medial or lateral in the ankle. It's most common between the ages of 8 and 12, usually during that adolescent growth spurt period. Just in case anybody's heard, so there's a difference between OCD and Panner's disease. Panner's disease is essentially an osteochondrosis, or that's still sort of loss of blood supply, specifically to the capitellum, usually in children under the age of 10. This is usually benign and self-limiting. It doesn't usually cause any pain. This is kind of an incidental finding seen on radiographs. They're usually maintaining full motion and does not require any type of surgery. So the pathoanatomy of what OCDs create, however, is a subchondral osteonecrosis, meaning at some point in time there's some sort of infarction to the bone. It's a bone problem that causes cartilage damage over time. So in this picture you can see above on the top right, you can see the loss of that bone creates a separation between the bone, hard subchondral bone, and the cartilage surface, which can cause instability and cause damage to the cartilage in the future. Doesn't necessarily related to trauma, but they do have activity-related pain, usually better with rest, worse with activity. 2-to-1 male to female ratio, and 25% of the time they can be seen bilaterally. So some risk factors for developing OCDs: repetitive stress. So our soccer players who are playing multiple games in a day, baseball overhand throwers, pitchers or catchers, as well as gymnasts. We see this a lot in their elbows. Family history sometimes plays a part. When we talk about ankle OCDs, those are more common after a direct trauma. Again, the adolescent growth spurt period. African American males seem to be the most commonly affected. And then any type of mechanical axis deviation. So increased varus or valgus can cause increased stress on a certain compartment, especially in the knee, which can lead to problems with OCDs. We also see this a lot in kids with bone metabolism disorders. So vitamin D deficiency, which seems to be pretty rampant, as well as we have a lot of kids we see on growth hormones and they end up with OCDs in their knees and in their elbows. So on exam, is usually localized tenderness in the knees, palpation over the femoral condyle and the elbow, direct palpation over the capitellum where it's most commonly seen. That usually causes pain. Stiffness, we see loss of extension of the knee and especially loss of terminal extension at the elbow. A lot of times they have recurrent effusions. It gets better, and then after they're playing on it, moving for multiple periods of time or playing in certain games, they have that effusion again to the knee. Mechanical axis we always look at if they're in varus, if they're in valgus, and then they sometimes have mechanical symptoms. When they do have mechanical symptoms like locking or catching, it's usually due to a loose body within the joint. So some imaging radiographs, sometimes they appear normal. So the radiograph you can see of the ankle, the very top medial is where that small little lucency is present, and that's that tiny little OCD that you can see. When they're large and they've been there a long time, they can look a lot more aggressive on radiographs. So we usually get 2 to 3 views of each joint to identify it in multiple different planes. Certain planes can help to define that OCD a little bit better, depending on if it's a more anterior or posterior lesion. Some special views that we use, especially in the knee, is the notch view, so where they're flexed approximately 30 degrees, and you can see on the more posterior aspect of the condyle. And then we get multiple obliques of the elbow to help identify these lesions, and then always weight-bearing films in the ankle. So our first case, this is back to our 17-year-old with the knee pain. You can see a standing alignment is perfect in neutral. However, you can see this sort of large OCD lesion over the lateral femoral condyle with what seems to be a sort of loose fragment, a progeny fragment within that piece as well. So where you see that lucency on the radiographs, that's our OCD. The second one, this is kind of hard to see. These are the type of radiographs where you're like, maybe if we look at it hard on the AP and that oblique, you can't really tell, but on the lateral, you can see that just subtle flattening of the capitellum right here. And then our third case, this is even harder to see on the AP. It doesn't seem like much, but then on the lateral, you see this small little lucency, this loose body fragment that's sitting within the joint, and a loose piece that's sitting posteriorly in the joint. So after radiographs, if there's suspicion of an OCD lesion, if you can frankly see it, we always get an MRI. That's the gold standard for our imaging. It helps us to determine not only where the location of the lesion is in a 3-dimensional plane, but also the size and the stability of the lesion. When we talk about stability, we're talking about stability of the bone fragment as well as stability of the cartilage. So in the ankle MRI, you can see here there's this cystic lesion, but the overlying cartilage is intact, versus this knee MRI, which you can see fluid behind this bone fragment, which means that there's a break in this cartilage, which is allowing that fluid to come underneath the cartilage and back behind the bone. That becomes much more unstable. So our first case, back to our 17-year-old, you can see this posterior lateral lesion. He's got fluid behind the lesion. I think it measured approximately 13 by 14 millimeters in size, but you see that frank break in that loose fragment, but still sitting where it's supposed to be on that distal aspect of the femur. Our second MRI, our catcher, our thrower, this is their MRI of their capitellum. So you can see where that flattening was, the small little loose fragment of cartilage, which is probably causing that catching he was having while he was throwing. And then this third MRI of our 14-year-old female with the patellar dislocation, we can't see that really bone fragment is now gone, but this indentation and loss of complete cartilage in that region. So we talk about OCDs, we have to determine what their healing potential. Not all OCD lesions that we see are operative. There's plenty that can be treated with just observation. So at diagnosis, children who are under the age of 12 with open growth plates have a much higher healing potential without needing any type of surgical intervention. As you can see in this X-ray and the MRI here, you can see this large lesion. It looks bad on radiographs, but on the MRI, you can see this huge cartilage cap, and it's well circumscribed posteriorly. The cartilage is not broken. Those do very well with just activity modifications. It also depends on the location of the lesion. So where on the knee, where in the capitellum, where in the ankle that you see these. The lesions over the more medial side of the knee heal much better than the lateral side. The capitellum heals better than the trochlear lesions, and then the lateral aspect of the talus heals better than the medial. And then again, the status of the articular cartilage. Is the cartilage intact? Is it broken? Is there a loose piece within the joint? All of those help to determine if these can be treated with observation or if they need surgical intervention. So different treatments. So we treat stable lesions with activity modification. So rest, rest, rest. They hate this. We usually let them bear weight, but just no running, contact activities, running, jumping, jogging. We limit those activities. Sometimes these lesions can take up to 6 months to heal. So we do have to have a long discussion about following them with radiographs every 2 to 3 months until we starting to see resolution. And then we treat the unstable lesions. So lesions that are unstable or they don't continue to heal with observation. We have multiple different techniques for this. We'll go over a few of these with the case-based, but we can drill into the lesions with cartilage that's intact. We can open up the joint and repair the cartilage that's there. And we also have different types of transplants of autograft or allograft bone and cartilage into those lesions. So the first case, these are their arthroscopic images. So he was our 17-year-old. He had a large loose fragment that was inside of his joint. You can see this is where another piece of that cartilage flap was still trying to hang on, but this is his subchondral bone. So we opened that up. This was his cartilage that was intact. This was the subchondral bone. We clean this subchondral bone. We drill it to make it bleed, and then we're able to repair this back down with just some vicryl sutures that don't have to be removed later. And so this is him at 2 months and 3 months post-op. I tried to get him to come in knowing we were going to give this talk to have a final x-ray, but he said he's doing great and he didn't have any time in his work schedule to return. But you can see that he's now a sclerosis of this part of that lesion. The cartilage is now intact underneath. This is our 2-week, we opened this up to debride it. So with the elbow OCDs, the capitellum is usually very small, so these treat well with just removing that loose fragment and drilling into the bone. So now you can see that we're starting to regain that roundness of the capitellum. He now has full range of motion. And then our third case, this was our 14-year-old with the patellar dislocation. And so she had a large loose piece. This no longer fit inside that lesion right here. You can see under the scope. So we opened this area up and we used an allograft transplant. So where we drill into the good bone of the distal femur, We measure out the size and then place a plug to make this now a nice round, smooth surface, articular surface. And that's all pressed fit. We don't have to use any type of screws or sutures for fixation. So this is her case at her 4-month post-op appointment and then 7 months post-op with her MRI. So you can see now nice round flatness to her condyle the way it's supposed to be, and you can see full incorporation of where her graft was placed. So how do we rehab them? We usually protect their weight bearing, especially after surgery of the first 6 weeks. They're plus or minus the braces. Some people like having the brace on, especially while they're just regaining their quad control, but they're usually full weight bearing by 7 weeks without their crutches. Again, no full contact activities, and these are for any of the kids who have any type of drilling, a repair, or an allograft transplant. We work on their range of motion right away after drilling. We don't restrict them in their range of motion at all. The repairs and any of the allografts, we do limit for the first 2 weeks just from 0 to 90, and then progress to full range of motion by that 4-week mark. They always want to know when can they start running. And so there's a couple different things that we have to identify and look at prior to that. So regaining quad control, meaning they're able to perform straight leg raises on their own without any type of extensor leg. Radiographic evidence of OCD healing, which is hard. This is the part that they usually get a little bit impatient with because not all OCDs heal in the same way, and they don't all heal at the same speed. Some of them heal very quickly, and they usually have radiographic evidence of healing by the 3 to 4 month mark. Much larger lesions that require more bone grafting and a larger repair or an allograft, they usually take about 5 to 6 months before they're back to doing this type of running. And so the return to sport, again, drilling usually by 3 months, they've completed their running program. As long as they don't have any recurrent effusions, we let them return to their sports. And then the repairs and the allografts, usually the 6 to 9 months. Any of the patients who we have that we do an allograft transplant on, where we use the actual bone plug, they get an MRI at the 6-month mark just to make sure that there's incorporation of that graft. Once it's incorporated, they're stable to start returning back to their sporting activities. So again, when is it safe? So radiographic healing, full range of motion, no joint effusions. And then the other thing we always talk about is there's always a risk that these OCDs can come back. We don't always understand why they get the OCDs or why there's this infarction in the bone. And so there's always a risk that if these return. So we try to promote their best bone health. I usually start them on vitamin D supplementation, even before and after surgery. And then any type of mechanical axis deviation. If they're in varus or if they're in valgus, and we do anything with an OCD, it's important to make sure that we correct them to neutral so that we can balance the forces that they're seeing, especially across the knee. So just some key points on OCDs. They're usually a vague type of joint pain that's associated with an effusion. It's usually worsened by activity. One of the biggest physical exam findings that we see are that loss of terminal extension of the elbow and loss of terminal extension of the knee. Location. So how they heal, how they act, if we need to do surgery, depends a lot on where we find them. The medial aspect of the knee is the lateral part of the medial femoral condyle is the most common place we see in the knee. That's also the place where it heals the best. The lateral side, not so much. The elbow and the capitellum, they usually heal very well, especially with open growth plates. And then the talus, the medial side heals worse than the lateral side. Radiographs and MRI are very helpful. We only use radiographs to help to determine if we see them at first diagnosis and then the potential for their healing as we follow them long term. MRIs are the gold standard. That's how we determine what size it is, if it's stable, how the cartilage looks, if there's any loose bodies in the joint. And then we only re-MRI the kids who have to have a transplant with an allograft or an autograft. And then and I know there's a lot of athletic trainers who are on this call, so as soon as we identify these, if you have someone who you can think may have an OCD, we take them out of play, rest them, and then refer them to an orthopedic surgeon or someone or non-op sports medicine to be able to get these radiographs and see what's going on. The larger lesions usually have been there a really long time. These are much easier to treat if the cartilage is still in place. And so we try to catch them as early as we can before the cartilage breaks and it becomes a much more difficult problem. So urgent referral, because we usually monitor these. I see them for several months. We become close friends, and then possible outpatient surgery if they need it. So thank you. I know I have a couple. I didn't know if we were going to go over some of these journal articles, or they are present. Some of the articles are in the attachment, and they just help to classify what OCDs look like, how we determine if they start to heal and when they're healing, and then some of the different treatment options. Again, talking about the younger kids heal very well with open growth plates. We just have to give them rest and keep them out of their sport. Versus the older teenagers with closed growth plates, the risk that these will heal on their own without needing some sort of surgical intervention is definitely much lower.
All right, the first question here comes from Michaela, and she asks, if you have any free or loose bodies found in surgery, what are the chances of something like a Macy biopsy?
So Macy is a great procedure that essentially we don't take the loose body and send it, but we take healthy cartilage from the notch and we send in, they grow like a cartilage like cap that we can then transplant into the OCD lesion at a later time. For Macy to work, you have to have an OCD that only has a defect in the cartilage, but with a good bone behind it. There's some better techniques that are starting to get researched and looked at about if you have a large bony fragment and a big sort of pothole. The bigger the pothole, the less likely you can use a Macy. But now we can bone graft and you can come back at a second surgery and still Macy over top of that. But they have to have normal neutral alignment, and then their bone stock has to be of good quality to be able to do that. But we definitely wouldn't take the loose piece out and send it. We take fresh cartilage just from the top of the notch that we send, and that they make that into our nice cartilage, essentially sticker that goes over that lesion.
And how long after do you go back in and put that in?
So it usually takes about 6 weeks to grow that cartilage. So then at the first stage, based on your sort of preoperative MRI, you can tell how big that bony fragment is. And as long as the bone looks good, you kind of go in with the idea to debride the area of cartilage, you harvest it, and then plan to go back in about 6 to 8 weeks to do the second stage. And then their post-op protocol is similar to after doing a drilling or a repair in an allograft. Still limiting their weight bearing, starting motion right away, and then watching for that to heal in.
If any other folks have questions, you're welcome to put them into the chat. And did you want to walk through one of those articles that you had included?
Yes, I can do that. So let's see here. All right. We could probably go through, let's see here. We'll probably have time to do two. So it's looking at which osteochondritis dissecans lesions will heal non-operatively. So this is a paper that came out of the ROC group, which is a multi-center study group that has essentially been collecting data on OCD lesions in their pediatric centers for, now this has been going on for several years. And so they're getting as much data, retrospectively and prospective data, as they can, and then coming out with these papers to help give us some guidance on how we're supposed to treat these. And so one of this first paper that came out from the ROT group is which ones can we successfully know that we don't have to treat with surgery. And so again, they had about 64 patients, 24 of them healed with non-operative management, which was only about 37%. They did a bunch of multivariable logistic regressions and other very smart people sort of statistics, and determined that obviously the larger an increase in size that you had by each 1% of a lesion, you decreased your ability for this to heal sort of non-operatively, which makes sense. The smaller lesions that are only a few millimeters have a much higher potential to heal versus the lesions that sometimes I see that are, you know, 1 centimeter to 2 centimeters in size. Those take much longer to heal non-operatively, or if they don't have good potential for growth, these don't tend to heal very well at all. And then what they did look at is the lesions that are more on the sagittal view or in the coronal view and the medial to lateral side. The far medial and the far lateral healed better than closer to the notch. And that has a lot to do with weight bearing. So if you think about the weight bearing surface of your distal femur, especially in your knee, the more centralized an area near the trochlea sees a lot more force than our most medial and most lateral. And so this was helpful to go in and show that these are predictors that can help us when we see patients in the clinic, and really talking with families and being, you know, this is something that we feel comfortable watching versus this is something that we may need to surgically help intervene to help with healing. And the whole point is to maintain as much good cartilage as you can for as long as you can, especially in my patient population of anyone under 18. We want to maintain as much good cartilage to get them into their 50s and 60s before they have to go see a total joint surgeon. And then one of these other articles, if there's no questions, move on to another one.
There is a question from Alyssa. She said, you mentioned if the OCD patient also has varus or valgus deformity in the knee, then you would correct it. Do you do this with hemiepiphysiodesis?
So if they have open growth plates, which is perfect, then yes, we can do what's a hemiepiphysiodesis, meaning guided growth. We use either percutaneous screws or little 2-hole plates, and you can help guide their growth depending if they have at least a year remaining. That's very helpful, and you can usually, especially if you catch them right before they go through their adolescent growth spurt, can use the power of their own growth to help correct that. If they come in and their growth plates are already closed, then if they're in valgus, we do a distal femoral osteotomy, and if they're in varus, then we do an osteotomy of the proximal tibia to help correct that. So when we see them when they're younger, yes, it's much easier and a much smaller surgery. And sometimes we don't even have to do anything to the OCD if we can just correct and offload that compartment.
The next question comes from Emily, and she said it was mentioned that this is an urgent referral. So what is the suggestion if it takes a while to get in?
Yes, so I always say my email and my phone number is here. It's really annoying when you're trying to get people in, especially if you see that there's a problem, there's an OCD, and especially if they're older and there's a loose body or this has been going on for a long time. So knowing people in the community to reach out directly to can also be helpful. So if you ever need anything and you're in the Lakeland area, I can help. Or I know lots of other surgeons in the Central Florida area who help take care of these. Yeah, it's kind of annoying sometimes just trying to get a referral and get people in.
And then Emily also asks, how common are OCD injuries in adults, and how does adult versus pediatric change the prognosis?
So in adults, I feel like in children, they quote being, 15 per 100,000. I think as you get into adulthood, and we're talking like 20 or 30-year-olds, that number probably is about the same. The problem with adults is once they get past that 30 to 40-year-old mark, they're treated much differently just because we have total joint surgery. You can do partial knee replacements. Their potential for healing, just because the bone does not heal in the same manner as someone under the age of 18 with open growth plates. I think more adult surgeons use a lot more biologics. I think this is much more common in pediatric sports surgeons like myself, just because one, we see it more often. If you catch it in a 20-year-old, this may have been present since they were a teenager, and at that point, the cartilage is probably not salvageable. Depending on the location, again, sometimes these OCDs can be treated with even large lesions with essentially a hemicondyle, taking a large graft and replacing it, but just allowing that bone to heal can take much longer of a period of time. So I think once they get into that 30, 40-year-old range, they're talking more about partial knee replacements.
Those are the current questions.
All right. Well, if we want to go over one more of these, which I found interesting, was the radiographic healing classification. This also came from a lot of the same authors who are part of the ROC group. And so a lot of times, even in clinic, we're staring and looking at these OCDs, and we're like, you put them up side by side from 2-month intervals, and you're like, it looks like it's getting better, but how do you classify it? And so what we're trying to do is how can we make sort of a way to discuss and talk about OCDs as they're healing, that where I could say it to one surgeon, they would understand what I was talking about. And so they looked at almost 500 patients over a 4-year period, and they found 41 OCD lesions that met their inclusion criteria. And so they were looking at least having 3 consecutive radiographs, because it's very hard to determine just based on 1 or 2 if there's reliable healing. And so they used orthopedic sports medicine specialists. They looked at these healing patterns. They came up with looking at the boundaries, so the size of the OCD lesion, if there was resolution and decrease in size. There was increased radio density of the progeny fragment, so that small bony piece, where we usually see dark black, means that's a sort of a new OCD or a not healed OCD. If it increased to look like more color of the condyle, that increased radio density was a good marker of healing. Or having both of the two or none at all. The boundary stayed the same. If they continue to have the large black circle, which shows that OCD lesion, then that was a lesion that did not heal. And so using these boundaries, the increased radio densities, or none of the above, they help to sort of determine and be able to classify these if they were healing well or if they had come to a standstill, which sometimes happens. They didn't see any difference between age, male or female sex, or lesion location, or the different treatment types. No matter how they underwent, those were 3 ways to kind of discuss and talk about in your radiographic findings if things are progressing and healing. Usually what we don't see is complete resolution until up to a year, where you no longer can see that OCD scar, and that usually is only present complete resolution in children who are very, very young and have the big wide open growth plates. But in the teenagers, you almost always can see that sort of sclerosis and that scar of their OCDs up to a year.
Comes with a nice picture. We have a couple of minutes in case there are any additional questions. There's about 75 people.
Well, if anybody has any questions and they think about it later, that's my email. You can always reach out. I enjoy taking care of these young athletes. It's kind of a fun, we see lots of kids with these OCDs who come into clinic. A lot of them are very, very young, and it's just hard enough to keep them off of like a trampoline to relax. But taking care of them, especially in like the young athlete, is a lot of fun. They enjoy kind of watching their radiographs heal as we go through it, and it's a challenging problem, but it's definitely something when we find it early, it's much easier to treat. But this is my pictures of my crazy daughter. She's 4. I hope she doesn't have OCDs in her knees. We give her lots of vitamin D. I wish we could put it in the water.
Okay, there's a question here coming from Diane. And Diane asks, functionally in the athletic training setting, what would you describe as the key signs and symptoms to be concerned about an OCD and trigger a referral?
I think anyone who has insidious onset of swelling in their knee, so they didn't have that like non-contact pivoting that we all get worried about ACLs. They were just playing over time or throwing, and then they just have this swelling to their knee. They have the swelling to their elbow, and they almost always, especially in the elbow, they start losing terminal extension. So not a lot, but they'll lose the last 5 to 10 degrees of extension of their elbow. And in their knees, especially with the effusion, they usually lack that last 5 degrees of extension. So effusions that aren't necessarily associated with trauma and loss of extension of the elbow and of the knee. The ankle is very, very uncommon. So usually if they're just having nagging ankle pain for more than 3 or 4 months without having necessarily any sprains, then I would send them at least for an x-ray. The ankle is one of the least common, which we didn't really touch a whole lot. And we don't, the good thing is we don't see them very often, but the elbow and the knee, those are usually the most common. Especially if they're overhead throwers or gymnasts who walk on their hands, then we always, especially when they start losing extension, we get radiographs and MRIs to make sure they don't have any OCDs.
Well, great. And thank you so much for sharing your time and putting together this presentation and going through some good articles with us. So everyone has Dr. Fink's contact information in case you want to get a hold of her. This was definitely a well-requested topic that you guys have put into your requests. And so if you have additional topics that you want to see reviewed, please do not hesitate to put those into the feedback. We're getting lots of thank yous coming into the chat now. So thank you very much, Dr. Fink, and thank you everyone for sharing your time with us tonight.
Thank you.